Hello everyone. My name is Helge Gilja. I am past president of EFSUMB and the current chairman of the Education Committee of World Federation of Ultrasound in Medicine and Biology. We will now go through the new guidelines on gastrointestinal ultrasound, and the ultrasound is used in this fascinating landscape of intestinal and GI tract. It is indeed a great challenge to ultrasound to scan the abdomen, but I will try to show you through this lecture that you can actually make very good pictures and do very good for your patient by scanning the GI tract. EFSUMB has for many years delivered guidelines on different aspects of ultrasound, and in 2011 these came out, the guidelines on contrast-enhanced ultrasound on non-hepatic application, and this guideline has been cited over 1,000 times and have been used quite a lot around the world to help patients with diseases of non-hepatic origin. We in this guideline had the first ever GI recommendations on how to scan the GI tract using contrast-enhanced ultrasound, and after that we started an important work also for general scanning of the GI tract. In 2014 we established a task force group of over 20 experts from all over Europe to start the very important work of establishing different guidelines on GI scanning. In 2016 we gave out the first guidelines on methodology and examination technique, and this was followed out by a guideline on inflammatory bowel disease published in 2018, and then we went on with perineal and rectal ultrasound with acute appendicitis and diverticulitis, and Mischellaneous disorders like celiac disease and various upper GI disorders published in 2019, and early this year we had the 6th guidelines published on intestinal emergencies. Right now we are finishing the functional disorders chapter, and we are now ready for submission. So in this lecture I will take you through some of these guidelines. But of course I do not have time to go into depth in all the guidelines, and some will be covered also by the other lecturers of this webinar. Based on level of evidence, we try to characterize the various levels using the Oxford Center of Evidence-Based Medicines scheme for grading of level of evidence. These can be graded into 1A, which is systematic reviews of high-quality 1B studies, and further down to 5, which is expert opinion. The grade of recommendation can also be characterized from A, B, C, 0 and X, where A is the best one based on good evidence, and C is based on expert's opinion, and X is when it is contraindicated. The EFSUMB guidelines on GIUS, the first one was on methodology, and I will start by giving you some points from this lecture. 19 recommendations were included in this one, published in 2016. And as a kind of basis for GIUS scanning, you have to use 2 different transducers, a low-frequency curvilinear array we use to get an overview of the abdominal content, also bowels in relation to other organ systems. But if we want to do detailed scanning of the GI wall, characterizing the different wall layers, we need to use a high-frequency linear scan head. We teach our students a systematic approach to abdominal scanning, where we use 6 different stations and 1 plus, and the plus refers to GI scanning. When we finalize the systematic approach in station number 6 here in the hypogastrium, then we use the 3.5 linear curvilinear array, and we can get access to the rectum and deep parts of the sigmoid colon by using the urinary bladder as an acoustic window. Having finished using that transducer, we changed the transducer and start scanning the bowels in a systematic fashion, typically in the right iliac fossa. In this region, both the appendix is localized, the cecum, and the terminal ileum, which often has Crohn's disease affection. Then, having scanned this region, we sweep the transducer in an ascending direction up to the transverse colon, and then we scan the transverse colon, and finally we get down the descending colon into the sigmoid part. So then we have a systematic scanning of the colon, and after that we can scan the small bowels by a principle called mowing the lawn in a systematic fashion, back and forth like this and up and down like this, in order to detect target lesions of the bowels or other signs of pathology. We need to be aware of the different wall layers when we scan, and typically you can observe 5 different wall layers using ultrasound. We have the histology section on the left side, mucosa, muscularis mucosa, submucosa, the proper muscle layer, and serosa and subserosa. And these correspond nicely to the ultrasound layers seen on the right panel, where we have the different layers in black and white. However, be aware that every time an ultrasound wave is passing through a new layer, an interface echo is created, giving rise to a hypoechogenic small thin layer. But apart from that, there was a perfect correlation between histology and ultrasound. The wall thickness in different parts of the GI tract can be depicted in a diagram like this. And mind you, the thickest part is in the antrum and in the rectum, and of course also in the sphincters. However, be aware that the intestines between these 2 outer points are really thin, usually between 1 and 2 millimeters. And using ultrasound, you're actually able to observe this and also measure the size of the wall thickness. If you apply Doppler, you can also get quick and rapid information about vascularity of the bowel wall. And this can be useful, for instance, in patients with IBD to detect degree of inflammation. Mind you, to put high sensitivity on the Doppler curve like this. And if you use Doppler, you are actually able to save life in a quick way. For instance, this patient was scanned through the liver here in the upper epigastrium, and we could observe these large dark areas here. And if you put on the Doppler, you realize that these are blood-filled varices in a patient with portal hypertension. And such a patient, if you detect that, you should immediately refer to upper endoscopy for band ligation or similar treatment of a very dangerous condition. Our second guideline was on inflammatory bowel disease, and there will be a separate lecture on that later, so I'll just give a few hints. In Crohn's disease, you can, using ultrasound, observe the typical transmural activity as shown here, where the inflammation creeps through the wall out into the surrounding fatty tissue, which then become hyperechogenic. Furthermore, you can apply the Doppler, like here, to observe if there is flow in the stenotic portion of the small intestine, or whether there is less flow. These can give a hint on further therapy. Using contrast-enhanced ultrasound on the bowels, you may also give valuable advice to how to treat the patient. This was a patient with an inflamed portion here of the jejunal loop, but this area caught our interest. There seems to be a kind of dead space here with a fistula arising in the GI wall, and we could follow this fistula route further down into the tissue, and further down we encountered an abscess cavity. And interestingly, this patient was scanned with MRI the day before, and they were not able to detect this fistula and this abscess on MRI. So ultrasound here gave a very good solution to the patient who could receive the proper treatment. Our guideline number 3 was about acute appendicitis and diverticulitis. And these are important issues in the field of GI scanning, and we gave our 21 recommendations in this paper, and there were above 80% agreement for each of the recommendations. I will give you one example, as this also will be covered in a later lecture. Diverticulitis. Maybe you don't think you can image a diverticulum of the colon, but that is fairly easy, particularly when they are inflamed, as in this case. You can see a thickened wall here, both of the colon and of the diverticulum wall, with increased fatty affection around the diverticulum and increased vascularity and blood vascularity around and in the diverticulum, indicating acute diverticulitis. Our guideline number 4 was about rectal and anal diseases. And in these patients, we often apply both perineal ultrasound externally, but also endoscopic approach through the anus. And this image shows a rectal tumor, and you can clearly in the ultrasound image see how the wall is thickened. You know, there is a great limitation with endoscopy, being able to view only the surface, but using ultrasound you can see right through the wall how the tumor is involving surrounding tissue, and you can do a much better stratification and give advice regarding prognosis using this method. It's also possible to apply elastography in rectal tumor staging. Here you can see a lymph node, and upon elastography it is blue, meaning hard, indicating that this lymph node in this tumor setting might be malignant. We move on to our guideline number 5, which was about different diseases, among them celiac and other cases, and there were 19 different statements in this paper. I also show you just a few examples. Celiac disease is something we also can observe upon ultrasound. However, you know that upper endoscopy and biopsies is crucial to the diagnosis. We sometimes observe a slightly thickened bowel wall thickness. Often we observe lots of lymph nodes in the surrounding tissue in the mesenteric. One characteristic for celiac disease is the so-called Waschmaschinen-phenomen, as it is called in Germany. This patient was fasting, and you can still observe a lot of intraluminal fluid in the intestines and hypermotility, two classical key features in undiagnosed celiac disease. And if you observe these findings in a patient, you should refer to upper endoscopy to rule out or confirm celiac disease. Meckel's diverticulitis is a very rare disease. However, be aware, if you detect something like this in the ileum, you should be warned that this could be Meckel's diverticulitis. Classically, affection of the peri-intestinal surroundings, the fatty tissue, which gets hyperechoic, and you should refer this patient for surgery. A mucocele of the appendix may look like this, fluid-filled, clearly distended appendix, and these patients need special attention as they should undergo surgery also. Then we move to our guidelines number 6, which was upon intestinal emergencies. This is also an important issue, particularly for the surgeons, and we did 24 statements with consensus levels of agreement in this paper. Statement number 1 is that small bowel obstruction may be diagnosed by GIUS in the presence of dilated, fluid-filled loops over a length of at least 2-3 bowel loops or over 10 centimeters. Statement 2, increased peristaltic to and fro movement of small bowel loops and the detection of collapsed intestinal segments distal to a stenosis are important signs of mechanical bowel obstructions. And you can see there is high level of agreement on these two. I show you only one case of obstruction of the small intestine. This was a young boy who came to me for ultrasound scanning, having pain in the stomach and also some weight loss over the last month. And by putting the linear array on the abdomen centrally, I was able to observe this stenotic area here, giving rise to a huge prestenotic dilatation of the small bowel. And this patient turned out to have Crohn's disease. In our last paper on GIUS guidelines, we have focused on functional disorders. And this paper is not yet published, but is just about to be submitted. And we have included 13 statements on ultrasound in functional GI disorders. The main chapters in this paper are functional diseases of the esophagus, of the gastro-intestinal part, and also the small bowel and colon, and we have a discussion in the end of the paper. The role of ultrasound in functional GI disorders is first to rule out organic diseases, then to detect disturbances in motility and disclose pathophysiological abnormalities. And all these may provide hints for therapy and further workup of the patient. Here you can see the gastric antrum, the duodenal bulb, and the opening and closure of the pylorus. Regarding esophagus, we are able to show evidence of even tongue and oropharynx diseases, swallowing disorders. Sencke's diverticulum can be detected. In scleroderma patients, we can observe dysmotility. Globus can be looked upon by ultrasound, and also non-cardiac chest pain and achalasia. And GERD and hiatus hernia are able to be observed using ultrasound. This case is a case of achalasia of the esophagus, where you see an extreme dilatation of the esophagus with content and food inside, caused by this aggressive stenosis of the lower esophageal sphincter. And in a patient like this, of course, need intervention. And this can be easily detected by using transabdominal ultrasound in the upper part of the epigastrium, looking through the liver. In dyspepsia, we can use ultrasound to study contractility of the distal stomach, gastric emptying, transpyloric flow, accommodation of the proximal stomach, and we can also apply 3D ultrasound to calculate volumes of the stomach. And based on all this, you can perform an ultrasound meal accommodation test to really provoke symptoms in your patient and do simultaneous recording with ultrasound. Here is one example of gastric contractility. You can observe these indentations on the gastric mucosa, and live here you can see how a contraction is moving distally towards the pyloric region. You can also observe contractions in the small intestine below, and you can observe the 5 different wall layers here in the posterior wall and here in the anterior wall. We can also study gastric accommodation, and here you can see the upper part of the fundic proximal stomach, and we can calculate areas, diameters, and even volumes to study patient with functional dyspepsia. In this video, we can show both a liquid meal and a solid meal here in the stomach, and also duodenal motility below. And you can observe how the contraction of the stomachs are decanting off solid food into the liquid phase. Regarding the colon and small bowel, we can study irritable bowel syndrome, small intestinal bacterial overgrowth, the familial Gucci 2C diarrhea syndrome, and symptomatic uncomplicated diverticular disease of the colon, so-called SUD, and also give advice regarding chronic constipation. Is it possible to distinguish between IBS and IBD using ultrasound? Yes, in some cases you can do that. This is a fairly normal hostration of the colon, and if you see something like this, you would suspect it is normal. But if you then in the same patient observe the jejunum with increased wall thickness, then you can suspect an IBD, which this patient had. In symptomatic uncomplicated diverticular disease of the colon, on the right panel you can see a classical diverticulum with an impacted fecalith, and this is how it looks upon ultrasound. Thin wall, some air entrapment, and there is a vascular component in the periphery of the diverticulum. So in conclusion, the 7 EFSUMB guidelines show that ultrasonography is a useful clinical tool for diseases of the GI tract. The pseudo-kidney sign or target lesion indicates severe pathology of the GI tract. Focal lesions and dysmotility can be visualized in most of the GI tract, and GIUS can detect and follow various GI diseases. And these new EFSUMB GIUS guidelines sets a new standard for GI ultrasound imaging. And ultrasound takes you from vision to clinical decision. Like this lammergeier, which is rare bird, have an excellent sight to spot anything abnormal on the ground. We can use as doctors ultrasound to spot anything abnormal in the human intestine. Thank you very much for your attention.